We are live.
Good afternoon, everybody, and welcome to Module 10 on this myopia progression control certificate program, which is being run by All India Ophthalmological Society. To begin with, I would like to thank Dr. Namrata Sharma ma'am for making it possible to start this certification program for myopia. So thank you so much, ma'am. And we would this particular module will be on what are the future options for myopia. So I would like to introduce my moderators, Dr. Prasanna Venkatesh and Dr. Anshuli. So they will be further introducing the speakers and experts. So, Dr. Prasanna, yes.
Dr. Anshuli, you want to go first?
Yeah, but I think I'm not audible over here. Am I?
You are audible, well audible.
You're audible.
Okay, fine. So a very good afternoon, everyone. First of all, I would like to thank Dr. Jethani sir and AIOS committee for giving me this opportunity to moderate this session. I would also like to congratulate Jitendra sir and Dr. Namrata ma'am for organizing such a well-structured and forward-looking academic session. So the earlier models have already talked about epidemiology, the progression, diagnosis, and management strategies of myopia. And this module is especially about the future, the biomarkers, AI, and genetics. These are no longer some distant research concepts. They are actively being used in the clinical practice. So now the question is not just about how to stop the progression. It's more about how early can we identify the risk factors. So we have an excellent panel of experts today who will help us explore the evolving landscape. So I'll briefly introduce everyone. So Dr. Kavita Kalevni, she is the Deputy Director and Specialist in Pediatric Ophthalmology and Strabismus at Shankar Nethralaya, Chennai. Dr. Chandan Ganesh, I think ma'am has not joined yet. She is a consultant pediatric ophthalmology at Arvind Eye Hospital, Coimbatore. Dr. Shreya Shah, founder and director of Drishti Nethralaya, Dahod, and Dr. Kuheli Bhattacharya, pediatric ophthalmologist at Eye Care Clinic, Goa. So I would now like to request our first speaker, Dr. Shruti Nishant. She is the chief pediatric ophthalmologist at MN Eye Hospital, Chennai, and she'll be speaking about tear film biomarkers in myopia progression. Over to you, ma'am.
Just a word for Dr. Shruti. She is doing her PhD in myopia also, and she is a patent holder on a device which she has made so that we can objectively evaluate, how much kids are sitting outdoors or not. So it's very similar to a watch kind of object which kids can wear. There's Dr. Shruti. Okay. So she recently had her paper published in American Journal of Ophthalmology on tear film biomarkers for myopia progression. Yeah, here she is. Yes, Shruti, please go ahead.
Sorry, I had some patchy internet at that time. Yeah, so at the outset, very good afternoon to everyone, and I would like to thank AIOS and Dr. Namrata Sharma and Dr. Jethani for putting together such a great series, and I know how much of hard work has gone into it, and especially during the peak hours. So great work, and hope we continue to learn from myopia a lot. So today we're going to have some interesting topics, I'm sure, and I'll be talking about tear biomarkers, which is something that's coming up new in myopia. Are you able to see my screen, sir?
Yes, ma'am.
Yes.
Okay. So, biomarkers is not an old concept. It's something that's been there for a while, and in several diseases, in fact, both systemic as well as in ocular. What is a biomarker? A biomarker is a biological marker that is an objectively measured characteristic. It could be either physical, chemical, biological, and that indicates certain normal biological processes or certain pathogenic processes or responses to certain interventions. Why are they important? Because they're very crucial in diagnosing disease, monitoring how effective treatment strategies are. They help in assessing risks. They help in developing new drugs. And most importantly, of late, they are found to play a role in prevention of diseases. And I think that's where biomarkers come into play. What do role of biomarkers in myopia per se have? Well, they are in a 5-pronged setting. First is risk assessment. It helps us to identify certain children who are at risk of developing myopia. Of course, some genetics, some biochemical, and so on. Certain biomarkers could be good as screening methods. And one very good example of that is axial length and choroidal thickness. And they help in, projecting and screening myopia and looking at high myopia in the future. And the third is, of course, diagnostic. And diagnostic biomarkers, of course, again, axial length, and of course, newer modalities like uric acid in vitreous for pathological myopia have also been studied. And of course, staging. When it comes to staging, then we look at the different types of different levels of choroidal thickness and aqueous levels of certain compounds that can also help in predicting or staging myopia to a certain extent. And prognostication is another important area in myopia, where we look at certain aspects of the fundus and then see how the propensity to develop pathological myopia in the future could be based on those simple early signs like lacquer cracks and so on. So with this, why do we need to look at tears? Now, why tears? Because tears is a complex mixture. It contains over 500 solute proteins, lipids, electrolytes, mucins, metabolites, epithelial cells, hormones, and also foreign substances from the ambient air. And it is such a rich substrate for us to study. It's something that's present there. It's non-invasive, or one can say it's minimally invasive. It's easy for sampling, and it's reflective of the ocular status or the present ocular status of the eye. And it's very dynamic in the sense that it changes itself based on how the eye's current status is. And of course, processing of these tears are relatively easy. So of course, these are the reasons why we prefer to have tears. Now, when we look at tear studies, there are two ways we can collect tears. One is, of course, with the plastic capillary tubes. And in that, you can see that a small capillary tube with a capacity of 10 microliters can be placed at the lower conjunctival fornix until the desired volume is collected. And then it is transferred to a 0.5 ml puncture tube, and then it's centrifuged and to retrieve the actual tear fluid. So this is one way of doing it. However, there is a second way, and that is the humble Schirmer strip. Now, the Schirmer strip these are small pieces of Whatman 41 filter with an imprinted graduated scale. Now, these strips can be bent at the zero line and at 120 degrees and placed beneath the eyelid, probably between the lateral 1/3 and the medial 2/3. And the eyes are closed for 5 minutes, and the soaked part of the Schirmer strip is cut and then placed into the puncture tube. Now, it's important that you do not you do it immediately so that the process is quick. And also, it's important that you use a glove or something to handle so that you do not contaminate the strip as such. And once we place it into the puncture tube, we have the microcentrifuge tube. We have a known volume of 0.9% sodium chloride, which is added for over 2 hours to incubate, and then following which we centrifuge it into a 1.5 ml tube and then retain the fluid that comes from the paper itself. So this is more comfortable and reliable, and also studies have shown that the Schirmer strip can be slightly better predictor of dry eye and all the biomarkers as compared to a capillary tube. Okay, so I just want to take you through the thoughts of what happened in our study, and then maybe that we can discuss this further. So first question that arose to our mind was, why does myopia occur? One, it could be because of the increased near work or the lack of sunlight. And these are the two risk factors that have been time and again spoken of. What happens in increased near work? In increased near work, there's an increased mechanical strain, there's an increased accommodative effort, and there is dry eye. Whereas when there is lack of sunlight, you have increased vitamin D, you have a direct immune suppression, you have increased hormones, increased neuropeptide substance P, and certain endorphins. Now, all of this, if you look at it, the common factor that binds them both could be something like an inflammation. Now, this was the question that we had, that, both increased near work and lack of sunlight could probably be leading to a slightly pro-inflammatory state in the eye, which could probably be one of the reasons for myopia progression. So we were wondering whether there was this kind of a link that can be present between these two via these concepts, and that's what we wanted to explore. So what we already know is that in literature, inflammation has already been associated with axial myopia in conditions of inflammation such as allergic conjunctivitis and uveitis and keratoconus and so on. And these inflammatory cytokines that are released in the ocular microenvironment may lead to a scleral remodeling, which may lead to axial elongation. And this happens because of collagen breakdown, because of all the pro-collagen breaking collagenases and all the cytokines that lead to this scleral remodeling. And of course, previous studies do show that they have taken samples from aqueous and vitreous chamber, and they don't tend to have, I mean, of course, they are invasive, they are tough to acquire, and we wanted something that's simpler to acquire, something that's minimally invasive, and that gives us some solid results. So, of course, again, more evidence, and this is a very interesting paper based on which I had my research question, and that is role of chronic inflammation myopia progression. There's a lot of evidence where they found out across species that inflammation plays a very significant role in myopia progression specifically. And again, in collagen breakdown, you can see how the collagen breaks down over 21 days in chicks just because of monocular form deprivation. So what we don't know is what is the role of inflammation in childhood myopia, and could subclinical inflammation be a significant risk factor? The hypothesis that we had was a low-grade inflammatory state probably could be present in a normal child's eye, which may be associated with the onset and progression of childhood myopia. So we wanted to compare the ocular microenvironment in emmetropes, moderate myopes, and high myopes using this particular technique. And we wanted to evaluate the actual levels of the cytokines, and also we wanted to see whether inflammation could be related to something like dry eye or accommodation and so on. So we included 94 children between the age of 8 to 15, and we put them into 3 groups, group 1 with emmetropes, 2 with moderate myopes less than 6 diopters, and group 3 high myopes more than 6 diopters. We excluded children who had allergies, pathological myopia, any other causes for inflammation, so-called inflammation in the eye or in the body. We eliminated all of those children, and the tests that we performed were all of these. We did have some ocular surface testing as well as axial length and cycloplegic refraction, and my examiners were masked. So what we did was we collected the Schirmer's, using the Schirmer strip, we placed this is just a way to show it. So we just close the eyes and then we collect the tears. And once we collect it, then it was put into the microcentrifuge tube, and then it was stored at minus 80 degrees centigrade. And after which they were eluted in an extraction buffer at 4 degrees centigrade with agitation and used through multiplex ELISA. So we use the multiplex ELISA, which is the ELA machine. The ELA machine is a customized version of the ELISA technique, and it's from Minnesota. And this machine kind of has a preset panel into which we can put in with all the cytokine markers. And then we just kind of put in our sample, and then it finds out what's the level. So it was basically designed for dry eye, and following which we used it for myopia. So this was an already standardized machine that's used for dry eye. Hence, it was easy for us to adapt it to myopia. So when we looked at the results, we had almost the age and spherical equivalent were not very well matched. So we had to correct for it later on. But when we looked at wetting length, you can clearly see that the high myopes tended to have lower wetting as compared to moderate myopes and emmetropes. And when you look at the tear film break time and the tear meniscus height, all of it showed this kind of a gradual decrease in high myopes versus the moderate and the emmetropes. And again, this was statistically significant. Again, OSDI scores were higher in the high myopes and moderate myopes compared to the emmetropes. And accommodative lag specifically was higher in high myopes versus, and moderate myopes versus the emmetropes. Again, the rest of it, like accommodative amplitude, pupil size, NPC, NPA, were not statistically significant in our group. So then when we look at the actual levels, you can see that there was a definite, this beautiful graph that comes in. High myopes tended to have higher levels of IL-10, IL-1B, IL-6, ICAM, IL-17A, TNF alpha. All of these were statistically significant. There were higher levels in high myopes as compared to moderate myopes and emmetropes. However, when we looked at MMP9 and VEGF alpha, they did not have any statistical significance. Again, these are the real values of them, and you can see that all of these parameters had statistical significance. So what we did find was there was an increased level of all of these inflammatory biomarkers in children with moderate and high myopia compared to emetropia. And IL-6 and IL-1 beta was found to be a positive predictor for moderate myopia, high myopia, and also a subset of patients whom we saw had progressive myopia. We also found that wetting length on Schirmer's was negatively correlated with all of these biomarkers, which basically means that dry eye had some role to play in this. And we also found that progressive myopia was positively correlated with IL-1 beta and negatively correlated with accommodative amplitude. So again, it shows that IL-1 beta levels had a correlation, a positive correlation with progressive myopia. So IL-1 beta would probably be a potential biomarker for myopia in the future. And accommodative amplitude was found to be negatively correlated with IL-6, TN alpha, IL-10, and IL-17. Again, there is some role of accommodation that is also at play. So to conclude, this study was one of the first to explore inflammation in childhood myopia without any predisposing inflammatory situation in the eye. And we found that the inflammatory cytokines are indeed raised in the tear films of myopes as compared to emmetropes. And subclinical dry eye and poor accommodation could probably be contributory to this aspect. And tear film analysis could be a potential biomarker for myopia owing to its safe, effective, non-invasive, and simple technique. Again, what is the implication of this is that we could have anti-inflammatory treatment strategies in the future that could be targeted towards myopia control based on this. So, I mean, when we look at similar studies, this was again an interesting study published on dopamine levels in the tear fluid and plasma. Again, this was the first paper which got published, and this was from Narayan Nethralaya, and Dr. Jyoti Matalia was part of this study. And this was the first paper that showed about how the different levels of dopamine were in the tears. And of course, she went on to present some papers on how the dopamine levels were lesser in myopes as compared to emmetropes and specifically in the tear film. So again, between male and female, all of this, but I think it's important to say that tear actually works as a really good substrate to look at biomarkers. What is the implication of this? Now, there are really interesting studies that are coming up which look at certain drugs that could probably be effective in controlling myopia through the ocular topical modes. And again, these are more studies. This is a drug called diacerin, which again, affects expression levels of inflammation. So again, it's slightly an anti-inflammatory molecule that in animal studies has proven to actually regulate myopia progression in animal models. And then again, this is more information on that. And there's a drug called resveratrol, and resveratrol has again been seen to kind of have this anti-inflammatory effect and thereby control and curb myopia progression in animal studies. When this is about tear as such, but when we look at the entire picture, there are several other biomarkers that are indeed available with us, and they are under extensive study. Now, look at biochemical biomarkers. When we look at something similar to what we are seeing, there are several studies that have already been done, a couple of them on the tear, but more often on the aqueous and the vitreous humor, which is more of an invasive method. However, you can see that all of these molecules, including proteins and VEGF, have already been studied through an invasive sampling of the aqueous or the vitreous humor. And a couple of studies, especially the one from Guo et al., study something similar to that, to what we did, but specifically looked at high myopes and pathological myopes and found IL-6 and MCP1 to be a really good biomarker for pathological myopia. When we look at anatomical biomarkers, there are again several other biomarkers that are available. You can have, stuff like choroidal thickness, central choroidal thickness, choroidal vascularity index, foveal avascular zone, central retinal thickness, and flow area of outer retina. These are all found to be really good potential biomarkers in terms of OCT studies. So in myopia, it is found that choroidal thickness has found to be much lower than in emmetropes. Central choroidal thickness has been found to be lower. Choroidal vascularity index has been found to be lower. A larger foveal avascular zone, an increased central retinal thickness, and a decreased flow area of outer retina. Now, these are the areas where the active studies are going on. When we look at pathological myopia, again, all of these factors are being studied. And on top of that, what is being studied is the luminal area, the stromal area, and the subretinal hyperreflective material, and the foveal curvature itself, especially in posterior staphyloma patients, are being actively studied as anatomical biomarkers with pathological myopia. So these are some of the things. These are CNVMs. What you see here is these kind of dome-shaped, and in staphyloma, you see these In very large myopes, you see these kind of stretching of retina that happens to one side, and these are found to be really good biomarkers. Of course, why is choroidal thickness important? Because choroidal blood perfusion has now found to be one of the really important biomarkers in myopia, and it is found to be something like choroidal blood perfusion has been equated to myopia progression in such a way that certain articles even say that myopia is more of an ischemic state leading to inflammation, and that's what causes the scleral elongation. So we do not know which came first, but whatever it is, choroidal thickness choroids have a really important role to play in myopia. We also have a lot of genetic biomarkers with myopia. I'm sure Dr. Shelja will be discussing this further. There are several genes and SNPs that are involved, and a lot of studies going on in that aspect as well. So I think this kind of covers up the whole concept of what's happening with biomarkers in myopia. And thank you so much for your patient attention.
Thank you, Shruti ma'am, for a wonderful talk. Ma'am, I have a doubt. Is there any anatomical biomarkers for myopia with glaucoma? Because that is one thing that we are also trying to work hard to crack, because we are getting a lot of issues with sensitivity and specificity in OCTs as well as in visual fields. So any biomarkers that we can think of from an anatomical point of view, which
Yeah, of course, they're looking at the peripapillary atrophy areas and the beta and the delta areas, and they're looking at that, and they're saying that stretching of that more of that area has more propensity to go in for pathological myopia in the future. There's a lot of work going on in myopia and glaucoma as well, and looking at the tilting of the optic disc, and also they say the way it avulses a little bit. All of that also on imaging has been found to play a really important role. So a lot of exciting work on that, especially in the papillary atrophy area, PPE.
Thank you, ma'am. We'll open the session for the expert panel discussion. Dr. Kavita ma'am, Dr. Sandra ma'am, Dr. Shreya ma'am, and Dr. Kuheli ma'am. Over to you to start the discussion for the...
First of all, thank Dr. Jitendra for this, trying to get me into the middle of a work day. It's very nice to see that there are almost 45 people listening to this. And I'm really proud to say that Shruti's work is really wonderful. One question about the tear film study that you have done. Like, see, you said inflammation associated with the dryness correlates with that interleukin levels and all that, right? So do you have data, or do you have a comparison on only dryness without myopia, so that we kind of rule out, okay, dryness is not contributing to your findings and maybe not alone myopia? Like, I'm not sure if I'm framing the question correct, because a lot of these children that in your study had less, dryness associated, right? So is there a kind of a comparison which you could make, or did you think like that?
So
where dryness ruled out a child without Schirmer's, normal Schirmer's, having myopia, and or the interleukin levels or your markers, is there any correlation, or are we really, attributing the change in the levels of interleukins to dryness and not necessarily myopia? Is there a skew there?
Yes, ma'am. This is the question I always get, actually, because that's the question we also had, and we did solve it also. So what happens in these patients is they're not very frank dry eye. Most of the kids, they don't have clinically
no symptoms,
they're
right? You ruled out symptomatic dry eyes.
In fact, on the Schirmers, they all performed well. It's just this relative kind of thing that we are seeing. So we did, in fact, go back and do it. So this was one from the reviewers. This was one of the questions, and we did address it, that if we rule out dry eye from this whole thing, is myopia still associated with inflammation? And we did find that if you rule out, so what we did was we defined dry eye based on Asia Dry Eye Society as T-Beauty less than 5 seconds and OSDI score more than 13. So we took that particular definition and applied it to our patients. And then based on that definition, we ruled out those patients. And then we did this analysis again, and we still found the inflammation to be significantly associated with myopes. And so here we do see that there's this kind of a direct link that's there. But the numbers are really small for us to really, put our finger on it and say this could be there. We probably need to have more longitudinal studies to really put a causative link. We could probably say that there is some association directly and also through the dry eye paths that we see there, because also through the dry eye, if we ruled out other things like age and factors and we looked at dry eye and inflammation, again, there was a significant link there. So I mean, lots more to look into it because our numbers were small and it was a pilot study. So I hope I attempted to answer your question.
The simplicity of the study and the straightforwardness, it makes it really replicable. You can, any center or higher numbers can be easily done because the way you have done it is quite simple and easy to do in a busy practice as well. Right.
Yes.
So if we have more numbers, probably many of the answers will be,
Yes.
Wonderful.
I think it will be also important to know whether, this is responsible for progression or not. I mean, typically, there are 2 points in myopia. One is that there is like if you go with Dr. Sandra's study on AL upon CR ratio, we now know that, if your AL upon CR ratio is above a certain number, the chances are that patient would be myopic. But whether this also tells us beforehand that, this particular patient may progress further. So I think that is where the role of TF film biomarkers will be very essential to know that, which particular biomarker is responsible and which can predict beforehand that this particular patient may progress further. Because most of the studies are right now directed towards stopping the progression.
Yes.
Yeah, on similar lines. Yes.
Yes.
Yes, Shruti. So the longitudinal, even I was thinking about that only, that if you have, like, this is a cross-sectional study, but if you have like follow-up studies on the similar cohort, same cohort over time, and like how you have shown the numbers to be higher in high myopes. So in the control groups, are these inflammatory markers still present even in emmetropes, or they are absent? Or they are present in very small numbers. So what was your observation again with regard to the emmetropes?
With regard to the emmetropes, they were present in much lower levels. They were not completely absent. They were present. In fact, we also looked at similar dry eye results because we also have dry eye studies on similar things. So it kind of matched those, our high myopes kind of matched those levels. Our emmetropes did have, but they had significantly lesser values. Like I did project some of the values. It was almost 50% lower than the high myopes. So, but it's not absent. Definitely it was present. It was there. So, so I suppose that longitudinal studies will be the solution to the questions. And we'll need to look at the same cohort in a long term. And also we were thinking like, if indeed dry eye, then we could have one cohort who would be on lubricants and, just see how they do, whether that could be as simple as something like that. So, I mean, there's so many questions that came up after that, and we're trying to see how we can design studies better to address those questions. But it was very interesting that a lot of other study groups also came forward with good points on how we can take this forward. And they were also planning to do multiple studies based on what we could find out from this.
Another thing is
there is a question from Shreya, ma'am. She's not able to be audible. She's asking if you can add Meibomian study.
So what we did was we had one cornea specialist look at each child and look at the ocular surface from an objective manner, and before we put them on, because we wanted to be really sure they didn't have ocular surface disease. But we didn't really do a myopomography. Maybe we could add that. Were any of the kids on atropine drops? No, ma'am. None. I mean, we made sure all of that was ruled out because we knew there are so many confounding factors in this. So we really had to be extremely careful to select our patients, which is one of the reasons why we had such a small group. We had to have children who are absolutely fine and who had absolutely nothing else going on in their eyes. So.
And will the Sherman's it will create some reflex tearing, right? So does not impact the concentration of the biomarkers?
So what happened was, so that was another question, that what happens is whenever the Schirmer's, the wetting length would vary for different kids. So will that affect the final concentration? Because one may think that, if it's a 10 mm versus a 30 mm, a 30 mm wetting would have obviously have more fluid, right? So the dilution may be more, or conversely, the concentration may be more because there's more sample collected. But what eventually the lab work does is they kind of buffer it into the same amount of solution. So 300 microliters is what was ultimately formed. So whether or not the wetting length, however, it didn't matter, because ultimately it was all matched to a 300 microliter. And so we kind of negate the effects of the wetting length on it. And also the reflex tearing part of it, we did look into literature, and they're very particular that nothing should be applied on the eye before we take the sample. So it was important that no, even if it's reflex tearing, that doesn't matter, because ultimately you're going to dilute it to a same level with the same level of buffer, so that it equates to that particular microliter. But what's more important is that we don't apply any drops before collection. And all the samples were collected between 9 and 11 a.m. again, to watch out for circadian rhythm.
And there is a whole group of patients with allergic conjunctivitis who are already on some anti-inflammatory therapy, right? Like steroid or tacrolimus or whatever. So have you, just out of curiosity, we can try and see what happens, because they have been on it for many years. So would they not get myopia at all? Like,
yeah, sure, ma'am. I mean, lot of
they
interesting
do.
thoughts.
They do become myopic, right? In spite of being on anti-inflammatory therapy, we still do find myopia and myopic astigmatism in them.
But they are on anti-inflammatory therapy, no? So their tear film biomarkers they are protected by the steroids, it seems.
No, I'm just thinking. No, but still, it is not like the allergic conjunctivitis patient do not have myopia. I mean, they do have.
They are on chronic
and that's the reason I said that. That's the reason I said if mammography can be done to rule out the inflammation, pre-existing inflammation.
Yes, of course. That's point noted.
Thank you, ma'am. So now we'll move on to our next talk by Dr. Neelam Pawar. The topic is artificial intelligence in myopia progression. Dr. Neelam Pawar is consultant pediatric ophthalmology with more than 16 years of experience, and she is currently pursuing her PhD in AI in pediatric and adolescent myopia from University of Maastricht, Netherlands. Over to you, ma'am.
Thank you, Anishi, for that kind introduction. And at outset, I would like to thank Dr. Namrata Sharma, Madam, and Dr. Jiten Jethani, and all the panelists who have taken time from their busy clinic. And it is really very nice to see every Monday and Thursday all of us assemble for these myopia modules. The slides visible?
Yes.
So I will be speaking on artificial intelligence, mainly in pediatric myopia, no financial interest. So today we are in era of digital evolution, and we are in fourth industrial revolution. So really we have to think whether we are ready. Technology seems to be ready, whether we are ready or not. And if we see human intelligence, for years we were using our human brains to have a solution to a new problem, and though the process information is slower, but with artificial intelligence the process is faster, and AI works unlike human. It works 24 by whole day it works without taking any risk. So artificial intelligence is an engineering that develops program which mimics cognitive function of the human mind, and machine learning is a subset of AI which is having ability to learn without being explicitly programmed, and deep learning is again a subset of machine learning where complex algorithm and deep neural networks are there to train a model. So all these things were existing previously, but in recent 5 to 6 years we have seen a rapid revolution in all these, and day by day, if we say every day we see on some subject, some paper on AI. So machine learning can be divided into supervised and unsupervised, and supervised means, again, it can be classified into regression and classification. In supervised machine learning, we are having both input and output. While in unsupervised machine learning, only there is an input, we are not having output. And supervised machine learning can again be classified as regression and classification. And in regression we can predict a numerical variable. So we are having an output which is a continuous variable and input which is again also continuous data. So for example, a spherical prediction of spherical equivalent which is a continuous value, and input can be age, demography and biometric parameters, all of them being continuous variable. While in classification supervised machine learning, we predict a categorical variable, and here input is a labeled data set, but output, as I told, it can be categorical variable like the presence of myopia or not, whether myopia is present or not, or whether myopia, we are considering like a prediction of whether myopia is low myopia, moderate myopia or high myopia, or exit length is high or low. So there are various algorithms in both these regression and classifications, like linear regression, logistic regression, and with all this modification of regression, we are having different ridge regression, Lars regression. These regression, they are different from statistical things, because in statistics we do all the calculation based on some assumptions, but here it is like in predictive. These are different from the statistical regression. And then we are having various decision trees and ensemble methods like random forest and XGBoost and support vector machines. While in supervised machine learning, as I told, we are having only input data, and it usually works for all the hidden patterns, or whenever we are having a multivariable large data when dimensional reductionality is needed, then this unsupervised machine learning is needed. And again, in these deep learning, there is subset of generative AI and large language models. And we daily use these large language models as ChatGPT, which summarizes, translate and generate the human sounding text to convey various ideas and concepts. So before developing a model, we need a good data, and data is usually split into 80 by 20 or 70 by 30 into training and test data. And in training data, we do all the calculation, and then test data is not included in training data, and then there is a validation data, and later on it comes into real world to see the performance on the external data. So if we see the process of machine learning models, initial process is gathering the data, and I think this is the very difficult task for us to gather a large good data. And then comes the cleaning of data, how to deal with the numerical data, how to deal with the categorical data, and then various featuring things we have to do in this data, how to replace the missing value, what method to use to replace the missing values. And then comes the exploratory data analysis, and then there are various feature selections, and then we have to see for what thing we are using this model, whether for the classification task or the regression task. So as in our coding, we always, like right now it has become very easy. 2-3 years back, literally we have to sit and see what codes we have to apply, but with the AI thing right now, so many things AI do itself. It will do everything for you. It will do hyperparameter tuning, all the parameters it will set to us, and within minutes it will give you all the data. And after the model training, there are some hyperparameter tuning things which we have to do, and then later comes the model evaluation. So there are various metrics we will see later, and then we have to do cross validation. It depends upon whether you are going to do 5 cross validation or 10 cross validation. It means with every training set and test set 5 or 10 times you are repeating those things to validate it in your test data. And then once you have trained the model, and then comes the evaluation of the model, and then final deployment of the model to make prediction, and then the model is complete, and then we have to see whether it is applicable in the real world or not. And this is the very important task, because most of the study we will see they will have, like most of the study, they lack external data validation. Only few studies, even in myopia, there are only few studies which are actually externally validated. So machine learning usually deals with all about these biometric, age, demographic, and all other clinical parameters, our environmental and behavioral parameters. And deep learning is again divided into neural network and conventional neural network. As our human neurons, they transmit information and they are organized in this way. Similarly, a neural network is also organized this way. And if we see convoluted neural networks will have an input layer, and then there are various hidden layer and then output layer. So whenever we put an image, then there will be so many hidden layers, and output we will get a predictive model. And depending upon the input layer, the number of hidden layers, then there are various algorithms. So imaging data, if we see every image, whether it is our ocular image, whether it is our facial image, fundus photograph, anterior segment OCT, RNFL thickness, choroidal thickness, each and every data contributes somewhere in myopia prediction and progression. So both the image data and non-image data, they undergo pre-processing, feature extraction, and then into the model development. So the non-image data and image data, there will we can have different analysis. Only with image data, non-image data you can do analysis. With image data you can do analysis, or along with combination of both of these, we can have multimodal models which can predict the onset of myopia, can predict the progression of myopia, can screen the myopia, can have risk stratification, can predict the outcome of the treatment, and so many other things. So in summary, if we look, AI can be divided into machine learning and deep learning. With the clinical data, these are some clinical data. There can be endless number of clinical data, and right now, along with our sleep pattern, along with melatonin level, and what Shruti described, along with our immunomarkers also, as a data, so many studies are going in AI. And then with images also, all with this fundus photo, pupillary red reflex, OCT, corneal topography images, also we can have models. And then there are mixed model which takes into account both clinical data and images. And to how to assess these models, so there are various metrics. For classification metrics, we are having accuracy, sensitivity and specificity, positive predictive and negative predictive value, and ROC curve. For regression metrics, we are having adjusted R-square. So usually if any value which is near to 1, it is considered as good, and absolute error, if they are lower, it is considered as good. And whenever we are talking about images, we use the term dice coefficient, which actually measures the overlap between the predicted and true segmentation. So higher is the dice coefficient, it says that it is good for that particular model. And usually for all the AI paper, we will see they will describe everything about sensitivity, specificity and ROC curve, which is the plot between sensitivity and 1 minus specificity. More the curve is towards the A, more towards it is 1, better is the model. So model whose prediction are 100% wrong, they will have a AUC of 0. A model whose prediction are 100%, which is impractically like not possible, they will have a AUC of 1. So why about myopia? Like in myopia, daily we see there are endless number of papers on myopia, because myopia prevalence is also increasing, and the projected prevalence of myopia by 20 to 50 is also increasing. So myopia is a hot research topic, and again AI in myopia is also research topics, because it is not only a single problem. There are various studies on AI is going on in genetics in myopia. There are so many micro environmental components along with the biometrics country, demographic factor, and then combination of all these factors. And even at the cellular levels also, we are having so many studies from choroidal lab, and also for the axial elongation rate also, so many studies are going with AI. So till now with AI, we are having so many studies in myopia, accounting into mainly three type of data: clinical data, fundus photograph, ultra wide field fundus photograph, and OCT. And in 25 to 26, what we are seeing, the studies are more focusing about fundus tessellation density, about vasculometrics, and about imagomics. So with more data coming into a clinical field, right now, countries like China and Singapore, they are having large data and large, so many good models to in the field of myopia. So in myopia, AI plays a role in early screening, risk stratification, progression, and prediction of spherical equivalent, timely and individualized intervention, and the ongoing management. And in adults, the deep learning is in children. We need not to bother more about the myopia related macular complication, but in adults, it is very important to see the fundus changes and myopia related choroidal changes. And again, so many studies are going on myopia related gene. So as I discussed, there are main two data: clinical data and imaging data. What are the clinical data? Cycloplegic and non-cycloplegic refraction, axial length, corneal curvature ratio, AL by CR, vitreous chamber depth, uncorrected and best corrected visual acuity, IOP, behavioral data, reading distance, outdoor activity, illumination condition. And if we see all these data, they are in numbers. And beside this, about weight, BMI, and psychological state, sleep duration, all these are quantitative numbers. So there are various studies done based on these data, and it depends from each and every study. Some study takes very large variable of data, and some studies take only cycloplegic and non-cycloplegic refraction, best corrected visual equivalent, and demographic factors to predict the progression of myopia. And this figure just shows that with machine learning algorithm, random forest, support vector machine, XGBoost, these are the commonly used machine learning methods. And with imaging data, CNN based model, and as I told, depending upon how are the type of layers, there are various this residual network, which are again dense net, efficient net. There are various residual network depending upon their layers. They are used in various studies. So this algorithm shows that whenever we are having a medical data or image data, all of them, they undergoes after data cleaning and feature selection into training data set, test data set, and with various algorithm. At last we get a trained model, and then fine tuning the model, and then we get a final ready models. So in myopia, AI is used more commonly in so many aspects. In visual screening, if we see, there are almost more than 15 studies which tells about that using these algorithm, mainly deep algorithm, using facial images with pupillary red reflexes, with photo refraction, and with non-cycloplegic retinoscopy, people have shown that they can not only identify the presence of myopia, but with the cycloplegic retinoscopy, people have also quantified the myopia. And in a recent study in JAMA, this artificial intelligence for early detection of pediatric disease mobile phone, they have found that just with simple mobile phone at home, parents can see with this GRAD map whether myopia is present or not. So these are just the qualitative analysis, which are very useful for visual screening. Again, this is a large study, which it was a prospective clinical trial in which the authors in a large school screening, they just identify children with this VGG algorithm by seeing the child fundus photograph, whether the child is myopic or non-myopic. Again, the question arises whether these models, whether they are applicable to different ethnicity or not, we really don't know. This is algorithm. It is from Singapore National Eye Center, and really they are having a very wonderful program in which they collect all the data at every hospital, and for each and every patient, the system is like that. They do. The system automatically does everything. So they will have a AI automated analysis of patient data, what we call as in Hindi, whatever the Jan Kundli, they will have everything ready for you with your data for myopia progression. And after screening comes the prediction and progression of myopia. So there are various clinical parameters like demographic and biometric parameters and annual progression rate. So Lin et al. Were first to do this. They did almost in patients data of 1 lakh in China, and they were first to do a random forest model to predict the progression of myopia. They did this study with a retrospective study of 8-year follow-up, and after that there is a series of studies. Every study either retrospective or prospective, and every study tells whether SD boost is good or random forest is good or support vector machine is good, or there is a neural network, MLP, multi-layer perceptron. So every study goes with their own depending upon their the parameters which they have taken in their study. Annual progression rate, again it is an important factor because every ethnic population will have a different annual progression rate. So before employing these data, these model to any ethnic population, it is very essential to consider that from which ethnic population these models have arises. So after the machine learning models in 2023, the focus mainly came on the inclusion of deep learning algorithm with the inclusion of fundus picture, and this study showed that whenever we are combining the images and clinical data, the AUC are quite higher. If in this study they show a AUC of 0.977 to 0.980 when we are combining both the clinical data and fundus photograph to predict the progression of 5-year risk of high myopia. And China has, this is a really landmark study of 1.6 million children fundus photograph, which they have taken from 7 centers in China and externally validated on Hong Kong population and Singapore population. And in this, they simply took the fundus photograph, the non-cycloplegic data, age, sex and axis length, and with this model they are able to detect the presence of myopia or not, whether the patient will develop, there is a risk stratification, what features they can do for outdoor intervention, and then again they are predicting the onset of myopia after 1, 2 or 3 years. So really this is a very good study because it has shown external validation also. So in AI application, as I discussed, all these models are used, and right now what has changed from 2023 to 2025, that from fundus photo we can see the parapapillary atrophic changes, the macular and parapapillary fundus tessellation, and how is the arrangement of the vessels at their branching angle, how is the choroidal vascular index. All these are again considered as surrogate biomarker in the progression of myopia. And so many studies are there on fundus tessellation density, which tells us that macular fundus tessellation density is an essential biomarker compared to the parapapillary macular tessellation density in the progression of myopia. And then coming to monitoring devices, in the progression of myopia, we are having various devices, but there is only one study which has actually calculated these, and SVM model was used to analyze that how was the indoor and outdoor activities, how they relate to spherical equivalent. And again, there are endless number of studies in adults based on fundus images for the prediction and for classification of various myopic maculopathy. But in children, as I already mentioned, that we don't have so much of myopic maculopathy. So main aim is to predict the spherical equivalent from the fundus photograph and to predict the progression of myopia. And again, this is about the adult study, that how we can, how this AI can help from the OCT images to predict the myopia traction maculopathy, the onset of CNVM, and other myopic related optic neuropathy. And then about the axial length, again there are 3 studies which tells about how we can predict the axial length in children by using the age, spherical equivalent, and demographic variables. We did presented this paper last year in ARVO. This was a clinical study based on hospital-based population of around 5,123 patients. A multicentric study in which we analyzed how these machine learning approaches, they are better to traditional statistic models in predicting the spherical equivalent among myopic children and young adolescent. And we did a SHAP analysis also to see what are the predictors in the for to assess or to estimate the spherical equivalent, and most of these models found that uncorrected visual acuity and axial length by corneal curvature ratio are in top of the predictors. So along with this model, whenever we use this explainable AI in the form of SHAP analysis, we really get which predictors are responsible for the onset. This particular study was just to estimate the spherical equivalent, but there are various studies which do see that what are the predictors which can help us to see for the progression of myopia also. And as I said, the era is going towards imageomics. We are also doing some studies taking the fundus images of children, assessing their optic disc shape, parapapillary atrophy, and their fundus tessellation. And this is a really very interesting study in which they have predicted the AL by CR ratio from the school children by the fundus photographs. So really the world is advancing, and besides this, the large language models have also helped not only the clinician, but they have also they are useful in educating the parents about the myopia. Only thing, whenever it comes about the treatment and about the myopia control glasses, somehow these ChatGPT and other this Gemini, they don't give so much accurate result, but otherwise they are very good in providing the education about the myopia risk factors. So maybe the population, compared to the population, the prevalence of myopia is not so high in India, so we are lacking behind. But if we see from China, they are having each and everything in AI. They are having artificial intelligence study in the air pollution, about the green space, and then they are having so many multimodal high myopia research biobank in which they are collecting the high myopia patient blood to detect again the progression and to do so many things about myopia. So what is the real world applicability of all these AI models? Really, these AI models are black box. We sometimes really don't know what is going inside whenever we do calculations. And all these studies, they are mainly from the Asian population, mainly from China and Singapore. So whether they will be applicable to Indian population or whether they will be applicable to US West population or European population, we really don't know. And again, the data quality and biases is important concern. And again, there are various medical, legal, and ethical consideration. And at last, I should emphasize that we have to be vigilant. We have to educate ourselves, because AI should not replace and cannot replace humans. And to keep a check on each and everything, there are various we can say there are various authorities which keep on checking that whatever model developed, whether it is correct or not, whether it is real world applicability is correct or not. So various things are going on this area also. So keep learning, world is changing. Thank you.
Thank you, ma'am, for the wonderful talk. Ma'am, regarding the black box phenomenon which you were telling in AI, we did a study similar to that, where we used human in the loop machine learning, where we had 2 human arms, one to annotate the images and one human arm to actually validate the annotations. Whether the training images and testing images were different, but the testing images, when put into the box, if they were right, then we closed the loop, or we again went into the training arm. So any of your opinion on how we can bring the human intelligence or human in the loop machine learning?
See, I am more involved with the data thing. I'm not more involved with the like images. But what in data things I have found, like, see, there are right now so many things. Just like with all our statistical software, if we do some analysis with R, it will give it can give a slight difference. If we do with Stata, it can change some variables, not so much, but some variable it can change. So similarly, similar cases with all these machine learning things also. With each and every model, the results, just as ChatGPT, same question if we ask endless number of time, it will give, we keep on asking, it will keep on giving hallucinations, and at end, maybe if 100 times we ask, we don't know, because of that fatigue or because of that training module, it can give an entirely different answer. So even not with what you are saying, not with a single time, if we keep on rerunning all the test, it gives on every time different result. Like I do with Google Colab, and with there is another thing, Auto Glue On, which is again a part of Google Colab. Same thing, same data if I take, it gives a slightly variable result, because everything is trained in that's why what it keeps on doing, that is what that black box name is there. We don't know.
Okay, thank you, ma'am. Let's open the session to panel discussion. Yeah, over to the panelists for panel discussion.
Dr. Nilam, ma'am, have you included parental information like refractive status of parents and siblings, because you have added all environmental factors and everything in that? So have you included that also for AI?
Yes, madam. We are doing one prospective study. That study is the myopia study, which is about myopia progression in children and adults. So in that study, we have taken in, so it is an ongoing
Parental
study.
information, yeah.
Yeah, so we have taken a parental information, but we have taken only whether parental myopia is there or not. We are not taking
Okay.
into account the spherical equivalent. We are
Okay.
just asking, like sometime we do ask, but not in each and every parent. It
Yeah.
is very difficult. Like they don't know. Sometimes husband will not be knowing what his power is. Sometimes like wife will tell some other power, will hide. So that's why we are not taking into spherical equivalent, but yes, we are taking into account of parental myopia and all other environmental factors also.
So I don't know. I really have very less to contribute. I really, it's a learning what Neelam is presented. We have very less experience with AI yet. So I think you are the one who is teaching here.
All of us, we are learning.
Yeah.
And actually, for everywhere, AI is actually immature right now. So let's wait for the results. It's immature, no? AI itself is immature.
But
I think
phenomenal research involved in this presentation. The number of articles that you have referred to make this presentation is truly commendable. I think it would have taken months to make this.
No, it is like 10% of my thesis. So
Okay.
I cannot
Right.
show, like we have what we from all data bases, what we search, it was almost 150 studies overall in AI in overall in myopia, and particularly only for pediatric myopia we are having 70 studies, and last month I think 3-4 studies were more added. So that's what it is, only just 10%. I cannot, if people will go mad if I will tell all those studies.
congratulations on your work, Dr. Neelam. It was amazing. It was amazingly exhaustive.
Yeah,
Sir,
thank you.
yeah, thank you. Jitendra sir, shall we move to the last set?
Yeah.
Yeah. So next we would like to call upon the last speaker of the day, Dr. Shailaja Tibriwal ma'am, who's going to speak to us on role of genetics in myopia progression. Over to you, ma'am.
Thank you, Prasanna. Am I audible?
Yes, ma'am. Slides are not fully in the slideshow.
Yeah, I just made it.
Yeah.
Is it okay now?
Yeah, perfect. Yeah.
Just move this.
Ma'am, just take the mouse inside and click on the screen. And after that, you can use the arrow marks.
No, I'm using the arrow. I just wanted to, make this toolbar go away. Yeah. Yeah. So at the outset, again, thanks a lot, Dr. Jitendra Jethani and Dr. Namta Sharma for this amazing, certification course for myopia. And the topics in the previous webinars were also so amazing. And this one specifically is quite a unique thing, which is not very often discussed in most of the myopia forums. So I would try to do some justice to this topic that has been given to me, which is role of genetics and myopia progression. And as the previous two speakers had also tried to summarize all these vast topics and the latest research going on in myopia, the field of genetics is also ever expanding, and it is difficult to summarize it in 15 minutes. So the outline of my talk would be, one, I would just go through what is the evidence related to the role of genetics and heredity in myopia. How much is the role of genetics in myopia? Then what are the various genes and loci which are associated with non-syndromic myopia? Then we'll talk a little bit about syndromic myopia. And finally, the applications of genetics in myopia onset and progression. So I've tried to keep it as basic and simple and more pictorial as possible, So one thing that we need to know about, and we all know about myopia, is that the influence of parental myopia on the onset and progression of myopia in children. So this has been there since a long time, maybe more than 20, 30 years, that we know that if the parents are myopic, there is a chance that the child will be more myopic. And this meta-analysis way back in 2015 had shown that the odds of a child having a myopia was 1.53 times if one parent was myopia, and it increased to more than 2 times if both parents were myopic. So definitely there is some heredity or some role of some genetics going on here. From India, there is one study which was published again, not way back, it was recently in 2022, where they had taken all children who had myopia and seen and emetropia, and seen how much percentage of their parents were having myopia. So an emetropic child was having 25% chance of having a myopic parent, one or both, but a myopic child had almost a 50% chance of one or more parents being myopic. So this is again pointing towards a role of parental myopia in determining the risk for having myopia. There are certain other aspects also apart from this risk of myopia, that risk of onset that I spoke about. This risk of myopia onset becomes higher if the parents are highly myopic. So not just the parent being myopic, the degree of parental myopia also determines the risk of the child having myopia. So highly myopic parents, more chances the child would be myopic. And also not just that, these children tend to have myopia onset at a younger age than their peers. Not just that, having a parent with myopia increases a child's chance of myopic progression. And again, some studies have shown that there would be fast progressors, including our own unpublished data, where we had more chances of fast progressors having a parental myopia. Children of myopic parents have also shown that the axial elongation is faster. This is again related to the pre-myopia, that in children of parents who have myopia, the children were found to have a axial elongation, fast axial elongation, followed by onset of myopia. So even prediction of a pre-myopia becomes more common in a patient who has a parental myopia. The next important connection of genetics with myopia are the twin studies in myopia. Now, twins, because they share most of their genetic makeup, they are even if subjected to similar environmental or dissimilar environmental conditions, because of having this strong genetic overlap between the twins. The heritability of a particular disease brings out or comes out more more often in twins. So in twin studies, based on the various populations, almost 50 to 90% of the myopia becomes heritable. What does heritable means? Means the variance in the myopia can be explained due to genetics or heredity in 50 to 90% of the times in twins. And various twin studies right from 1960s, 70s to late to 2010s or 2010 have shown that twins definitely share this genetic constitution, and that is why so much of heritability of myopia is there in twins. However, when you moved on from monozygotic or dizygotic twins to siblings or to families, then the heritability of myopia reduces. What does it mean in simple language is that the moment you come to an individual in a family which is not like directly, they're not twins, then the amount of myopia that you can attribute to heritable causes or heritability reduces, which essentially means that even if you have shared genes, other factors become more important, which in myopia case are the environmental factors. So myopia does have a strong genetic influence, but environmental influences also play a major role in this disease. So that we need to understand. So once we know that yes, myopia has a heritability angle or there is a genetic angle, then people have invested the time and energy in finding out myopia associated genes. So earliest in 1990s, linkage studies were done. Now, what is linkage studies is that at that point, these high, type of high-end genetic tests were not available. So if you know that a particular trait is located at a particular chromosome at a particular loci, then if that same trait co-segregates with another trait, for example, if in a family, all the children who had a darker hair also had myopia. So if you know the loci of dark hair, then you can know whether you can predict that the myopia locus would also be associated close to it. So that is how linkage studies were done. So you essentially needed large pedigrees of multiple family members being affected. So these kind of studies were done, but even in them, almost 26 myopia loci were found, and at various chromosomes, on various chromosomes. These are usually rare mutations and have the large pathogenic effects. Okay, so they in the family where they were found, definitely they were associated with myopia. But the problem with linkage studies was that they were seldom replicated in subsequent studies. So then later on, people started to focus on candidate gene studies. Now, candidate gene studies focus on the pathways. For example, if we know that there is scleral elongation or scleral thinning in myopia, so what were the genes which are involved in scleral remodeling? So those genes were targeted, and those were looked for in myopic patients versus non-myopic patients. Similarly, retinal signaling or dopamine pathway. So these were the ways in which candidate genes were identified. Then with the main most recent advancement is the GWAS. GWAS is genome-wide association studies, and these are basically case control studies. Like you take large number of myopic patients and you take large number of emmetropes and you compare the single nucleotide polymorphisms. Now, what a single nucleotide polymorphism is that these are variants of that allele at a particular nucleotide level, which are present in population in a concentration or in a frequency of more than 0.05%. That is, a minor allele frequency is more than 0.05%. So essentially that means that it is not really disease causing, but it causes a susceptibility or increases your susceptibility to the disease. So GWAS has identified more than 450 common genetic loci, which predisposes us or patients to a myopogenic effect of their either the environment or even without the effect of environment, they are susceptible to develop myopia. So large consortia like the UK Biobank and the CREAM consortium have pooled the data and found out several loci, and some of them are the GJ2 and the RAS GRF1. And lastly, whole exome and whole genome sequencing, they are identifying rare variants of early onset high myopia genes, especially the syndromic and the ones which are associated with systemic disease. So this is just some of the genetic loci associated with myopia. These are the common ones from that 450 that I've just selected. So just showing that they are also involved in either retinal signaling pathways or scleral remodeling pathways, regulation of development. Surprisingly, PAC6 is also here. Then they are linked with axial elongation. And they have some clinical relevance, which is shown in disease that, some of them are protective, like the ZC3H11B, and some of them are markers for fast progression, like the ZFHX1B. So all of these clinical relevance have come from various studies which have, seen all these SNPs in various JIVA studies. Again, the problem with Jiva's studies is that if you replicate to various populations, you may not get the exact score for different populations. So ethnicity plays a role in these Jivas. So what is the more interesting concept that has come in recent times is the polygenic risk score for myopia. So it is there for ARMD, it is there for glaucoma, and is now being developed for myopia. So we know that myopia is polygenic. Now we could see in previous slide that there was almost 450 genetic loci which have been identified, and more are being identified as we speak. So what the polygenic risk score does is that based on hundreds of thousands of these SNPs which may be present in a particular person, it can calculate a integrated risk score or a polygenic risk score for that particular person. So it kinds of leads us to precision medicine in myopia. So I'll just go through brief how this polygenic risk score is calculated. So from this Jiva study, you have so many SNPs that have been identified. So each variant is selected from that and is given a weightage depending on how strong the odds ratio came out in the study. So, and then what happens, all of these which are present in a particular patient, suppose a patient had 10 of these or 20 of these, then that allele count of that particular variant and the weight is multiplied, and then all of these is then added to get you a total polygenic risk score. And a top 10, if your polygenic risk score is more than 10%, that means you are a high risk of that particular trait that we are studying. Either it is myopia onset or progression. So that is how polygenic risk score is calculated. So it is very important for early risk stratification. It has been used to identify children at risk before even onset. So this is especially used in pre-myopic children with a family history. It can predict the risk of high myopia in a particular patient. This has implications for preventing pathological myopia. It can lead to personalized myopia control. Like if you are at high risk, you could have an early initiation of atropine, more aggressive control strategies, closer follow-up schedules, or even outdoor exposure or lifestyle changes can be instituted if you know your polygenic risk score. And you can combine it with the different other risk models, as Dr. Neelam was speaking, and you can combine PRS with the other risk models to give you an integrated risk model, which could really move us to real precision medicine or predictive medicine in myopia. But there are limitations in with the PRS. PRS explains only a part of the total heritability, and as such, I mentioned, if you integrate it with the environmental factors, maybe it would become a better predictor. It varies according to the ethnic groups. It requires population-specific calibrations. It is not yet present in the routine clinical practice. And of course, there is a cost and accessibility concerns as of now. But it has future prospects. You can imagine a world where it is integrated into pediatric screening. As mentioned, it could lead to precision ophthalmology. With more evidence, we could have improved polygenic models, and we can even institute it at population level for public health use. Now, as mentioned in the previous talk also, that myopia is not just genetic, okay? And it is not just environmental. There are so many factors, and it's an interplay of all of these factors which really lead to myopia development. So myopia is a multifactorial disease. That is the baseline, okay? So another important factor which comes here is the epigenetics here. So what is epigenetics really? Epigenetics is how the behavioral and environmental factors, they cause a reversible. So here we have to understand it is a reversible change, but it is heritable change in the gene expression. But it does not cause any change in the DNA sequence. So your DNA sequence remains the same, but how the gene is expressed, because how probably it can help, how the gene expresses can, change the way your disease expresses in you. So this is how does how do the environmental factors change the DNA, gene expression? Could be due to through DNA methylation, through histone modification. These are how the proteins fold, and that is how they express, and even by affecting the non-coding RNA or silencing, that is the promoter regions and all. So epigenetics also does play a role in myopia. And all the environmental factors like the lack of sunlight, excessive near work, education level, and all these have been studied, and they affect the expression of these genes. There are several studies. I'll not go into the details of all of them, but most important risk factors which have been found are higher education, in which the studies which are done is that they take the genetic markers and they compare it between patients who have higher education versus lower education. And then the odds ratio in one of the study was found to be 51 if you are highly educated, at the same time you have the myopia genetic loci present in you, compared to presence of myopia genetic loci but no higher education, which is odd ratio of 7. These studies have identified loci which are influenced by education status or near work. As mentioned before, if these polygenetic scores are combined with this environmental performance, then they give you a best predictive performance. So basically genetics plus epigenetics combined can give you a better predictive model in myopia. Now coming to the more simpler type of genetics that we understand is that the syndromic myopia, but it is yet very, very important. So I've just enlisted few common disorders which are associated with myopia. So connective tissue disorders are the most common ones which we remember. The Stickler syndrome, Marfan syndrome, Ehlers-Danlos, and the Knobloch syndrome. In Sticklers, you would have patients who have very high myopia, and they would have an optically empty vitreous. They would have hearing problems, sometimes skeletal problems. Marfan's, we all know, has heart defects, eye ectopia lentis, long limbs. Ehlers-Danlos has hyperelasticity of joints and skin. And Knobloch syndrome is high myopia and severe eye problems with occipital skull defects. Coming to metabolic disorders which can cause it, the homocystinuria. Here it is important because it mimics kind of Marfan's but can have cognitive impairment and thromboembolic, life-threatening thromboembolic events. So need to differentiate it from Marfan's. Gyrate atrophy, where it can lead to chororetinal atrophy and high myopia, and the LCHAR deficiency, which are posterior staphyloma and again chororetinal atrophy. You can also have other retinal dystrophies not associated with metabolic disorders, but be associated with myopia. So if a myopic patient after glasses also is not improving in vision, you should think about retinal coexisting retinal dystrophies, because RP, CSNB, blue cone monochromacy, and albinism, all of these can be associated with moderate to high myopia, even low myopia. And the last and other forms are the myopia which is associated with ROP, or just prematurity itself, and other syndromes like Down syndrome and Stratsma syndrome. So this is a simple algorithm which I kind of follow when a patient comes to the clinic, is that if a child with high myopia comes, you have to confirm the measurement, and measurement is not just refractive error. You have to look at the biometric parameters, especially the axial length, the corneal curvature, and you have to understand whether the cycloplegic refraction is explained by the axial length. If it is not, then definitely there could be lenticular problem here. Then you think about the age of onset. Now, if it is early age of onset, like less than 6-year-old child presenting with high myopia, have a high suspicion for genetic and syndromic cause. So, and based on the previous slides, that if you see a tall stature, think Marfan, short stature, think Weil-Marchesani. If you have a mid-facial hypoplasia and hearing problem, then you think about Sticklers, developmental delay and thrombosis, homocystinuria, and all these things that mentioned. If the child has all these problems, then you have to have a genetics referral or do systemic evaluation based on what you're suspecting. Now, patients who are 6 to 10 years old, which are the school age going, If they present with high myopia, look for which other factors, risk factors for high myopia they have, especially the ones like parental myopia. Was there a rapid axial elongation? Does the child is a habitual reader or excessive near work, and there is a reduced outdoor time? So these are the risk factors which can predispose children at 6 to 10 years of age to present with high myopia. If these are absent, then look again for the red flags which mentioned, like is there a lens subluxation, is there abnormal vitreous, disproportionate axial length, and if those red flags are there, then you again refer for clinical genetics evaluation and the other evaluation as I mentioned. Now, age, if it is more than 10 years, usually these polygenic myopia which were covered in the previous slides. They also have high progression. They also have strong family history. But if they do not improve in vision after giving glasses, then think about retinal dystrophy. These are some of the red flags, again enumerated. I think it is already covered in the previous slides. So the practical applications of genetics in myopia is that myopia genetics has taught us who to refer for systemic evaluation. Okay, these are the syndromic high myopes. Who to treat early or aggressively. This could be risk stratification. Either just take parental myopia into it, or if we take, a polygenic risk score. My genetics has taught who to monitor early, that is those who have parental myopia, and again those who have PRS is high, and which pathways to target in research. Okay, so because of all these loci which have been found, and they have been found to these different pathways, more and more research on delving into deeper aspects of these pathways, which may lead to some, therapeutic modalities in future, are also underway. So, but with as mentioned in previous talks also, there are limitations. We all know there is no gene therapy for the common myopia that we see yet. And looking at all the factors that we have seen in the previous slides in the presentation, is that it might be difficult to have a single gene therapy for the common myopia, because it is not really a single gene disorder. PRS is there, but it is not yet in routine practice. We know that we need ethnic calibration for that. It is not easily accessible. And finally, it is a multifactorial disease. So genetics plays a part of it, but not the full role. So I thank you for your patient listening, and all my mentors and the team. And if people are interested in genetics and more learning about rare diseases, then this is one meeting that I'm organizing in April 4th and 5th this year. And people can, register and come and, witness more of genetics and ophthalmology. Thank you.
Thank you, ma'am, for such a wonderful and enlightening session. You have explained such a complex topic in a very easy manner.
Is it?
We got to know a lot. I had a question, ma'am. Suppose a child has a strong genetic genetic risk, but he has not yet developed myopia. So can we intervene with the drugs or the spectacles? Something we can do about it?
That's
so yeah, so there are studies for pre-myopes and for parental myopia, and people have started using, and people do use both. It has been used, low dose atropine has been used, and even the myopia control glasses have been used in certain studies. It really depends upon the population. I mean, if it is a very like in Chinese population and in other Asian countries, where it is a very public health concern, the prevalence of myopia is as high as 80-90%. So there the risk of myopia progression or myopia onset in the child is very, very high. So there they are justified to do it. In clinical practice, I also practice that, especially if both the parents are myopic. But I don't start low dose atropine for prevention of onset of myopia, just because I don't think to the clinics these patients come. But if a patient comes to me and both parents are myopic, I would start them on some prophylactic treatment for preventing progression, because I've seen that presence of parental myopia is one of the biggest risk factor for myopia progression, and that too fast progression.
I would request our expert panel to please join the discussion.
Again, here the expert is the speaker. Actually, she's Dr. Shailaja. Like in your like, have you had any experience or thing about, now we have so many modalities of treatment, right? So response based, like which myopia genetic implication and response is there any correlation in your experience that you're looking at, or have you already looked at?
No, I'm
Like
I'm not
response
looking
to
at that.
atropine, response to those myopia control measures.
No, I'm not looking to that. I have looked at response to myopia based on the rate of progression, that is, a fast progressors or slow progressors, and based on that, in that multifactorial analysis, parental myopia was there. Although the patients who had fast progressors, the proportion of parental myopia was more in them, but the response to atropine did not depend on the parental myopia. It actually depended only on age and the axis length. So
Because
that was the only two things that we
because we
found.
still have a lot of, not so much clarity on why certain groups of myopes do
Agree.
not respond
Do
to
not
treatment.
respond. Agree.
So, yeah.
Yeah, that's it. And frankly speaking, genetic studies like these jivas and all, they're quite expensive. I'm not sure if anybody in India is doing jivas. I didn't see any published literature from jivas. Maybe people are doing, I don't know. But what specifically I do is that for the syndromic myopes or high myopes early onset, at least for those, we do a genetic analysis, the whole exome sequencing, so that we identify the syndromes and can guide them accordingly. But for the common myopia, doing these studies, I mean, we'll try to get funds and see it in future if we can do it.
The amount of myopia that we see, we can't.
Yeah, agreed.
Yeah.
We should do.
Excellent, Dr. Shailja. Excellent. No question. It was more than excellent. Wonderful.
All
And
three of you.
especially the algorithm you shared with everybody.
Yes, ma'am.
Was good.
I think the class is for all the experts today,
Actually,
supposedly.
Yes, true.
Yes.
Absolute true.
No, I also learned a lot. I was a little resistant because Dr. Jitani gave the topic quite recently.
Great. Yes.
But it's quite a vast topic, so I just tried to keep it practical as possible. But whatever
really
I
Also,
also
you covered a
All
lot.
three
Those
of you
experts.
have worked so hard on these topics. No, you already know more or less, like you are the expert. So that's the reason I was pretty confident that you will, all three of you will be able to pull it
All
off.
three of you were
Absolutely.
doing it that
Absolutely.
way.
talks were amazing, yeah. But these are thoughts for everybody. I mean, these are the ways myopia research would go ahead or go forward in the future. Definitely genetics is coming in a big way. But of course, there's a lot of funds and all revolved. And I think for all the three topics, there is a lot of scope for collaboration amongst India. And I think we have leaders from many institutes here, and we should all collaborate and see how we can, because resources are limited. It's not necessary everybody to replicate everything, and definitely think about collaborations.
Yes, we can do something.
So, those who have
Thank you.
registered for the program, the link for the question MCQs is there in the chat box. Just informing. I mean, they will have to answer the questions, the MCQs, which we put forward with every module. It is there in the chat box.
Again, all speakers are experts, and I thank Dr. Namrata ma'am and Dr. Jethani for allowing us to be part of this wonderful webinar where we learn more. Thank you.
Yeah. So
Thank you.
thanks so much, Dr. Anshuli, Dr. Prasanna, and the 3-star speakers, Dr. Shailja, Dr. Neelam, Dr. Shruti. And thank you so much, Dr. Shreya, Dr. Sandra, Dr. Kavita ma'am, and Kohli has left, Dr. Kohli, for taking out time. I know this is a pretty busy. It is just everybody finishes the OR and comes back to OPD. So thank you so much for full support for this particular certification program. The program itself was it was very, very quickly made up. So I know I could not give time to anybody, but thank you so much for supporting me completely. Thank you, everybody.
Thank you, Dr. Jethani.
Thank
It's
you.
very
Thank you so
difficult
much.
not to support
Thank you,
you too,
everybody.
Dr. Jethani.